My name is Camilla Andersen, and I'm a medical doctor at the Department of Cardiology at Hello Gentofte Hospital. Well, in the Empire Prevent Metabolic trial, we challenged the established treatment indications for SGLT2 inhibitors. As you may know, SGLT2 inhibitors, such as empagliflozin, were initially launched for treatment of type 2 diabetes, but over the last decade, the therapeutic indication has expanded more than once. And now the drugs are indicated for both treatment of type 2 diabetes, heart failure across the spectrum of ejection fractions, and chronic kidney disease. And in all these three populations, the drugs have improved heart failure outcomes. And recently, meta-analyses have suggested that this effect is evident even in patients without heart failure at baseline, which implies primary prevention of this disease. But we don't know currently whether this effect, the primary prevention of heart failure, extends to patient populations beyond current treatment indications, and this is what brought us to conduct the Empire Prevent Metabolic trial. The Empire Prevent Metabolic trial was a mechanistic phase 2 randomized placebo-controlled trial where we evaluated the cardiometabolic and renal effects of empagliflozin in patients at high risk of developing heart failure. We defined this high-risk population by including elderly patients who were aged 60 to 84 years. They were overweight or obese with a body mass index exceeding 28. And in addition, they had at least one extra risk factor for heart failure restricted to either hypertension, ischemic heart disease, previous stroke, or an eGFR of 30 to 45. And patients were excluded in case of a history of type 2 diabetes. These high-risk patients were randomized to receive empagliflozin 10 milligrams or placebo, and we followed them for a period of 180 days. At baseline and follow-up, these patients were subjected to a rather comprehensive examination program, and this included cardiac MRI as well as blood samples and anthropometric measurements for calculations of fluid volume parameters. The primary endpoints of this trial were the baseline adjusted mean differences in change of estimated extracellular volume as a measure of fluid volume status outside of the body cells. And for the second primary endpoint, we evaluated the change in ventricular epicardial adipose tissue, which is the amount of cardiac adipose tissue within the pericardial sac. So the two primary endpoints reflect two distinctly different mechanisms involved in heart failure development, namely hypovolemia and excess epicardial fat. Obesity predisposes to both, and SGLT2 inhibitors have previously been shown to reduce these parameters in other populations. So this is why we chose to examine these parameters. We found that 180 days treatment with empagliflozin significantly reduced estimated extracellular volume with an estimated treatment difference of 123 milliliters compared to placebo. Although this may sound a little bit modest, this change is of similar magnitude to what has been observed in patients with heart failure, where we know that these drugs have robust clinical effects. In contrast, we found no effect on ventricular epicardial adipose tissue in these patients. The secondary endpoint supported the primary findings. The first secondary endpoint was the change in estimated plasma volume, where we found an 8% reduction, again similar to what has been observed in patients with heart failure, as well as a significant increase in the exploratory outcome hematocrit, both of which reinforced the effect of fluid volume. However, we found no change in right ventricular end-diastolic volume index or in total epicardial or pericardial adipose tissue. The observed improvements in fluid volume parameters hold promising prospects for heart failure prevention in high-risk populations, particularly given that the changes were of similar magnitude to what has been observed in heart failure patients. In addition, it's noteworthy that we found a significant increase in hematocrit. Across existing landmark trials with SGLT2 inhibitors and other populations, this increase in hematocrit has been a consistent finding. And importantly, mediation analysis have time and again pointed to hematocrit as the most important mediator of cardiovascular and renal benefits. So we have reason to believe that this could be of clinical value in these patients. At the same time, this trial confirms the safety of SGLT2 inhibitors in this new population, finding the similar safety profile to what has been observed in other existing populations. However, despite these intriguing perspectives, we cannot conclude on the clinical implications yet. This was a phase 2 trial, so clinical outcomes were not expected with this relatively short-term follow-up duration. These results definitely challenge the established treatment indications for SGLT2 inhibitors. Our findings suggest that these drugs may hold a place as a preventive therapeutic strategy to avoid obesity-related complications such as heart failure. We believe that these results provide scientific basis for conducting future phase 3 trials, which should aim to clarify the long-term implications of SGLT2 inhibition in this high-risk populations of individuals with overweight or obesity beyond current treatment indications. Ultimately, to clarify whether the therapeutic indication for SGLT2 inhibition should be expanded once again.